Welcome everyone to the March 4th, 2021 COVID-19 clinical rounds. Today's rounds are focused on critical coordination of COVID, trauma, and the emergency healthcare system. My name is Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor at the National Healthcare Preparedness in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are those with the most experience. This is a voluntary public-private collaboration, and thanks to the multiple professional organizations who have collaborated on these rounds. These rounds are not intended to be redundant or replace any organization's initiatives. They are, however, intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National Emerging Special Pathogen Training and Education Center, NETEC, for their support with these rounds. NETEC's webinars complement these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Bruce Strumminger, who is taking a long-deserved vacation this week, and his stellar team here with us today for the peer-to-peer learning platform we use for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Mondays are EMS. I believe this coming Mondays is going to be focused on EMS and telemedicine. Tuesday, our critical care series, Dr. Jeff Dichter will be, who has been supporting us and coordinating a couple of these rounds, will be leading that one. And then on Thursday, following up on rounds over the past 6 weeks or so, where we've talked about pneumothorax, pneumomediastinum cases, we're actually going to focus on pneumothorax and pneumomediastinum for next Thursday's emergency department rounds. Wednesdays, independently, but also complementary of our clinical rounds, we will have HHS emerging outpatient therapeutics rounds, which are focused on monoclonal antibodies. I'll now turn this over to Amanda Dazan for ECHO.
Thanks. Hi, my name is Amanda Dazan with Project ECHO. I'm just going to go over a couple of quick logistics for today's session. So in the Zoom window, you'll see a Q&A function. Please use that for any questions or comments you have about the presentations. There's also a chat in Zoom. Please use that for any questions about technical or logistic issues. And we'll also be using that for a crowdsourcing question in just a couple minutes. Today's session is being recorded and your attendance is consent to be recorded. So thank you. The presentations from today are linked to the most recent email announcement that was sent out from us at Project ECHO this morning and will be found on our website along with a link to the recording once we have that ready. You can also find all the past sessions on there. We do offer CME and continuing education credits via the University of New Mexico, where we're located. The link for that is also in that same email announcement from Project ECHO this morning, and we'll put it in the chat about 15 minutes before the end of today's session. A quick reminder that the learning sessions are focused on improving patient care and health systems and supporting clinicians. So we appreciate everybody keeping things apolitical and non-commercial. A quick note about data use. You can read our full policy on the screen here, but we want to let everybody know that while we do collect data via registration and other ways that you participate in these sessions, we do keep all individual data confidential. As mentioned earlier, we do partner with NETEC and they have complimentary webinars to this series. You can go to their website, netec.org, and find upcoming sessions and recordings of past sessions. Another quick reminder that the AAMC does have a continually updated coronavirus clinical guidance repository, and you can find that on their website. That's right up there in the top of this window. And back to you with the crowdsourcing question.
Thanks, Amanda. After all this time, finding the mute button. Wow. All right. So the crowdsourced question is, this is one of those pulse checks. What concerns you most about the pandemic today? So like, we've been doing the long haul for sure, but please help share your experiences with others on Rounds. And if you could go ahead and participate in this one. What concerns you most about the pandemic today? With that, see, I already got the variances of response. That's okay. Yeah, let's keep those going so we can see what people are thinking about. With that, I'd like to have our panelists please unmute themselves for a second. Dan Gerard and Carol Cunningham. Carol, I'll start with you. If you could please briefly introduce yourself.
Good morning. I'm Carol Cunningham. I'm an emergency physician and I'm the state medical director for the Department of Public Safety here in Ohio with the Division EMS.
Thanks. And Dan Gerard.
My name is Dan Gerard. I'm a registered nurse and a paramedic, and I'm the president-elect of the International Association of EMS Chiefs.
Thanks very much, Dan. Welcome back, both of you. Today's actually a really special Rounds today because it's really trying to integrate our healthcare system in ways that can really support our response, not just for extraordinary events, but daily events as well. Well, I had a bit of a clunky title for this one. I actually think it really does represent the concept of medical operations coordination centers. I'd like to introduce our first speaker, Dr. Eileen Bulger. Dr. Bulger is chair of the Committee on Trauma with the American College of Surgeons, professor of surgery at the University of Washington, chief of trauma at Harborview Medical Center. Eileen, it's truly an honor to have you on Rounds. Please turn it over to you.
Thank you so much. Let me get my slides up for you. I'd like to thank you, Rick, and the Project ECHO team for the opportunity to share with you our state in our sort of journey in the regional coordination of our response to COVID. And I think that what we've learned in this journey hopefully can be a model for how we improve our disaster response around the country. We were the first major outbreak in the United States just about a year ago, occurred in the Seattle area in a long-term care facility in Kirkland, Washington, which ultimately had a very large number of cases and a very large number of fatalities. What happened in this event, because again, before the pandemic was really recognized, these patients were getting sick in a nursing home that was not far from a community hospital, and the patients were in there over the course of a few weeks to the hospital. There was no really coordination of the hospital, and that's where EMS went. And very quickly, that hospital became overwhelmed, and it really wasn't to the point that they were on their last ventilator that they called and said, maybe we need some help. And so the system really wasn't in a position to identify that this was happening or to respond to it in a meaningful way. The other thing I think that we've seen nationwide, and you see this if you follow the public media on these topics, is many places we have this problem where there's a lack of regional or statewide bed tracking systems. And so, the title here, hospitals are flying blind. The lack of communication among healthcare systems is a problem. In the competitive healthcare market, sometimes the unwillingness to share data becomes a problem. And there's just a general lack of a planning system in place that allows us to coordinate and redistribute patients when a hospital is in trouble. And that resulted in many places where there were hospitals that were overwhelmed, but then there were others that were really not that far away with empty ICU beds because they had stopped operating in anticipation of a surge. This is starting to appear in the literature as well. This paper looked at interregional transfers for patients using the data over the past year and really looked at national bed shortfalls, which were greatly in geographic areas based on resources and the number of patients in that area. But we're able to do some modeling around what it would take to redistribute those patients in a meaningful way to ensure that every patient had access to the highest quality ICU care. And I think this type of modeling will help us as we think about developing this system in the future. So when you think about the pandemic, really it's a sustained response. Obviously, we're a year into it now, which requires tight coordination and communication between our emergency management systems and then all of our acute healthcare systems. No hospital is spared in this event. And those are three groups that function very well independently, but in historically have not had to work together in this type of improve a level of coordination among groups in a sustained way. So I work at Harvard Medical Center. It's a level 1 adult and pediatric trauma center for the state of Washington. We serve as the disaster medical coordination center for the county and for the half of the state as needed, and have done that for many years and have drilled and practiced and stood up for events. And we're used to doing that for discrete events. But clearly this, and so as we stood that up early on in the pandemic, we realized that that needed to be a broader engagement across all of the hospitals. We also work with the Northwest Healthcare Response Network, which is our healthcare coalition funded by ASPR. That is a place where the hospitals come together to work on disaster planning and preparedness. So we worked with them to put together very quickly what we called originally the Regional COVID Coordinating, which was responsible for all the hospitals in the county and allowed us to quickly offload that hospital that was overwhelmed in the eastern part of the county, and then start to look at how data in a systematic way so that we could understand that quickly scaled up to cover all of Western Washington. And as of now is called the Washington Medical Coordinating Center because it covers the entire state of Washington. So I'm going to tell you a little bit of this story, but really we were building this plane while flying it in the middle of the pandemic. So it's not like all of this just turned it on. This was something we had to build. And I think that that story is valuable because it is feasible to do this. So this is the picture of sort of what we thought the functions would be at the center. We really had 2 surveillance arms and 2 coordination arms. So for surveillance, really what we're looking at is how can we collect data from all of the hospitals and health so that we could track not only the number of patients they were seeing with COVID, but also what their bed capacity was, what their staffing issues were, and what their access to PPE and ventilators were. We had the need to redistribute those things. We could do that as well. We also felt it was important that we set up a surveillance for high-risk populations, specifically those that live in congregant settings, because we had that first experience in a long-term care facility. We knew they were at high risk, but also in jails, prisons, shelters, and alternate care environments. On the coordination side, we felt that we needed, most importantly, to have a system that would allow us to do regional health system level loading, to take patients and move them from a hospital that was seeing a surge to a hospital with capacity, and to be able to do that in an efficient way in coordination with EMS. We also wanted to be able to coordinate with the public health in identifying outbreaks that were occurring in these high-risk settings. So to do this, we worked with Microsoft, who happens to be in our region, to very quickly develop a software platform that was quite sophisticated and easy to use. It allowed all of the hospitals to enter this data in real time on their staffing, their beds, their equipment, their ventilators, so that it could be seen in this, at the Central Coordination Center. And this really now has been adopted by the state, and it's called WA Health, and it's used statewide. And this is the type of data you can get. So this is King County, Washington. It's most popular. It includes Seattle. See there all the hospitals listed here. We could track in real time what the status of things were. Red is bad, obviously. People were over capacity, but we could figure out where there was capacity when we needed to move patients across the system. We could also then, as this scaled up to the larger state, look at statewide trends. And this was very valuable data for our public health colleagues as they were trying to determine restrictions related to the pandemic, they could see what the capacity was for ICU beds across the state changing over time. I think one of the key things, and one of the things that people tell me is a big barrier to doing this, is the ability to get everybody to agree to submit this data. And we went into this, fortunately, with the pre-existing relationships from our healthcare coalition, but very quickly put all the CEOs of all the major healthcare systems in a virtual room to work this out. And they agreed that we really, in this setting, needed to put aside any competition and be cooperative. And every CEO in the state signed an agreement that they would contribute in real time and that they would accept transfers as directed by the coordination center in order to level out the system. And that agreement has really helped us make this possible. And I'll just show you just some of the data from the last few months, just to give you an idea of the transfers that the coordinating center has managed. So we have very rural parts of our state with really critical access hospitals that have very limited ICU capability. So we were able to offload those. We had a big outbreak in the central part of the state where we offloaded patients from all of these counties really into the Seattle area. But we also moved patients around within our own county. So this system has allowed us to really understand where the hotspots are and deal with them. The next step in the evolution of the software is to be able to collect the data from the long-term care facilities directly. This is a little bit of a heavier lift, not for the software, but for the but our goal is to check this data so that we can identify an outbreak when it's occurring. The other data that we've been tracking is EMS data, which we do capture electronically, and that's a nice way also to identify if there's a problem happening. Because if you see all of a sudden a large number of EMS runs to the same facility within the time, you can investigate it a little bit further. So this can be a way to also identify outbreaks that are happening before they become out of control. So to sort of summarize, this is a map of our trauma system, all the trauma centers in our state. I think, from our perspective as trauma surgeons, we've been doing this and moving patients around for higher levels of care for a long time. But this level of engagement of all the healthcare systems, I think makes us stronger for all disaster response. And you can think about other large scale events, big earthquakes, large hurricanes, where this type of infrastructure could be stood up and very helpful in managing a healthcare response. So what does regional coordination offer you? It offers you situational awareness of everything that's happening across your healthcare system, both for the patients and for your resources. It provides you the ability to distribute patients among the hospitals, manage your pre-hospital care resources, ensure that your hospitals that are specialized for certain things like trauma care or stroke care available to be able to manage those problems. Manage crisis standards of care as a region so that no hospital is going into that scenario by themselves. Fortunately, we never reached crisis standards of care, but we were able to be sure that we were all in agreement as to the trigger. And then hopefully identifying outbreaks in high-risk populations. There are some resources online, a previous webinar that we did with ASPR that's on ASPR Tracy, and a very nice toolkit that's been put together by the FEMA task force on how to set up this type of infrastructure. And I think if we think about this as a vision for the future, if we had our sort of everyday trauma and emergency healthcare system, which patients around be able to scale up when needed to this type of regional medical operations coordinating center or coordinating cell, which is the government term. And then that data, if it could feed up to the local emergency operations centers, to the state, and then ideally to a federal system where you could actually look at a dashboard and see what was happening in every state. So I think that's our vision. I'm hoping that we can get there in the after action reports from the pandemic. I look forward to the discussion and thank you for the opportunity to tell you our story.
Eileen, it's a great story. And one of the things that I keyed in on are really it's like, yes, the CEOs, you mentioned the sort of evolution of the healthcare coalitions had, worked on developing the relationships, but that critical, okay, now the CEOs are engaged, and my guess is because it was like, okay, now it's the real deal, and something's got to be done, SGBD, and so they signed a memorandum of agreement, and how to I mean, how to create that like need in the long run, not need, but be able to do it in the long run and not just in a crisis to have that engagement, I think is critical. I mean, that's my, my concern thinking about this for the future is, well, we're not in a crisis. So do we actually need to like do this? So Eileen, a specific question for you before I turn it over to Ronnie. In terms of the state system that you developed, what are your thoughts in terms of like, if you do this nationally, not a national, not sort of federal centralized nationally, but if you do these regional coordination cells, medical operations coordinator centers, whatever you call it, the state versus a regional one, as in the state boundaries, as opposed to, okay, we're going to have a hub in Spokane, it's going to cross state boundaries. I'm sure that's been some discussion, so interested to hear your insights on that.
Yeah, that's particularly pertinent to us because we currently receive trauma patients routinely from other states around us, from Alaska, Montana, Idaho. And we did get some transfer requests out of there, which we handled with our current trauma system strategy. But I think that if we could have these in each state or in each area that could then link together, then that would make a lot of sense. And we didn't have situational awareness from those states. And so we were a little bit flying blind and trying to just accommodate their needs. And they're rural states, very high population centers. But I think that in the long run, again, if encourage area to develop this sort of strategy, and some states are really big. I think we'll hear about Texas in a little bit, where you have to divide it up because it's too big, right? But if we had this that they could link together and communicate with each other, then we would be able to do that without any trouble. I don't think those cross-border issues.
Yeah, the linking the regional ones together. Yeah, that exactly. With that, I'm going to turn it over, just based on timing, I'm going to turn it over to Dr. Stewart, just so you sort of see the flow. Ronnie, go ahead and if you can put your slides up. In terms of the flow for the remainder of our time, I'm going to turn it over to Dr. Stewart, maybe one or two questions, and then I'm going to go directly to polling because I think it could really inform us all in terms of how people are viewing these at this juncture and utilizing them. So with that, it's an honor to introduce Dr. Ronnie Stewart. Ronnie is the medical director for trauma programs at the American College of Surgeons and professor of surgery and anesthesia and chair of the Department of Surgery at UT Health Sciences Center in San Antonio. Ronnie, please, welcome.
Thank you, Dr. Hunt. It's a pleasure, an honor to be here. Thanks to HHS, ASPR, and all of our partners. I'm really grateful for the opportunity to present here today. I'm going to present about our Regional Medical Operations Center and the COVID-19 pandemic response. Even though I'm presenting, this is a total, complete team effort. A special shout out to Eric Epley, who's Eric is a paramedic who's been a key leader of our RMOC since the beginning, 17 years ago. So anything I'm saying is a total, complete team effort. So, but we do come into it from trauma system development point of view, which really I think of dealing with routine, mini, small scale disasters. Where really cooperation, communication save lives. So for the past 25 years, we've worked to build a trauma system in a really diverse area in Texas. And along the way, we basically made it a framework for disaster and then stroke, STEMI, mental health, and perinatal systems. So all those exist in our system. So really, we've evolved to an emergency healthcare system. I'll use trauma system and emergency healthcare system interchangeably, but it's really the same thing. Where I'm talking about is trauma service area P. It's this piece of Texas that's about 27,000 square miles. We use an inclusive consensus decision-making process that we try to focus on what's the right thing to do for the patient. And in this area, you know, it sounds a little weird in the sort of polar environment we're in, but we've never had a non-unanimous vote in 25 years. So I think the highlighting some of the things that Dr. Bulger said, you know, cooperation communication can really work even among intense competitors. This is a summary of a piece of the 9/11 Commission report. And to me, I see the echoes of this commission's report in the pandemic. You know, they identified key failures: a failure of imagination that this could happen, failure of policy, a failure of capability to have the right resources, and a failure of management to coordinate those resources. Really, RMOC, I think of as really its main function being on the fourth of those challenges. But really, I think it helps across all four, is a tremendously valuable asset. And just our experience from one region is that, you know, a functioning regional system provides a great framework for large-scale disasters and has been for the COVID-19 pandemic. And I know we do education drills, we emphasize them a lot, but they're not enough. It's just not enough. It requires regional communication. And the concept that Dr. Bulger nicely laid out is that this linked regional medical operations center, RMOCs or MOCCs, are really critical to effective disaster and pandemic response. She said this already, but these three systems, our acute healthcare system, public health, and emergency management, really must work seamlessly and flawlessly together. I'll throw in a biologic analogy. I know a lot of people are come to this from a health standpoint, but I think of it.
Ronnie, for
Yes?
2 seconds, I'm not sure your slides are advancing. Right now, we're seeing the introduction slides. Sorry to interrupt. I just want to make sure you're aware.
They're advancing on mine. Can we? I'm going to try. You're only on the intro. Okay.
Ronnie, Echo might be able to pull them up really fast for you.
For the Echo team, could you pull up the biologic analogy slide? I'm going to stop sharing. Okay.
Yeah, sure. Yeah.
Or you want to try to reshare? Let me try to reshare quick.
Try one more time. Yeah.
What do you see? I see a slide, biologic analogy, strong lungs, heart.
Nope.
Okay, Echo, would you mind pulling those up?
There you go.
Thank you so much. So I use a biologic analogy. I really appreciate that support, Echo. Thank you. Biologic analogy that, you know, if you kind of sort of break it down to a simple analogy, I think we have really strong public health, acute care, emergency management. So we have great lungs, we have a great heart, we have a really strong musculoskeletal system. But really, you know, what organ are we missing? Really, with respect to a wide scale event, we're really missing a central nervous system, the ability to respond and coordinate that care. So next slide, please. So we have MedCom. It's a trauma transfer system. It also now does mental health navigation for patients in mental health crisis. But this system does about 500 interhospital transfers a month, and it works across our entire health systems. Next slide. So we use that MedCom center as our kind of base, and that we simply upregulate to a regional medical operations center, which is tied physically and communication-wise into our emergency operations center, our local regional emergency operations center that's tied into our state emergency operations center, which could easily tie into a federal emergency management system too. So next slide. We've been doing this for a long time. We've used it for a lot of natural disasters, in particular hurricanes. We've load balanced thousands of patients in any given time, and it requires some agreements that Dr. Bulger said, but it's pretty simple, and it's not particularly expensive. We look at, you know, not activation costs, but if you look at we would estimate that for a big region, 27,000 square miles fully implemented, it's maybe $500,000 a year. Next slide. That's just the RMOC, an old RMOC way a long time ago, pre-pandemic in action, where each health system, each big EMS agency, they're in the room talking to each other, sharing data, looking at each other. Next slide. But really, for this to work, it has to work in real world conditions. This is a picture I took in Harvey. It has to work in real world conditions, has to be able to adapt. Next slide. It has a lot of advantages. Dr. Bulger talked about situational awareness. I think of it, you gain actually sort of a regional consciousness. You can sort of tell what's going on. Linked RMOCs allow for that system that we talked about. It allows for load balancing of a surge of patients, or load balancing if you have a loss of capacity at a given hospital or portion of the region. It enables healthcare regional response teams like coordinating hotspots, but other response teams as well. And it gives the ability to adapt in a very fluid and dynamic environment. Next slide. Next slide. So this is just data. This is the report we get every day. We send this report out. It's updated daily, and it goes from the very beginning of the third week in March to now. And you can see that we've had, we would say 3 surges, really two big surges. You can see it peaked at about 1,520 patients in our metropolitan hospitals. You can see that trend over time. You can see admissions. You can see ICU, intubated patients, ECMO patients, and we have the ability to break this down by hospital, by health system. It's done all the time, easily done. So really important situational awareness to what's going on in the region. Next slide. We developed a composite stress score. It's like Dr. Bulger said, while you're flying a plane, we developed this on the fly. It's quite imperfect, but it gives us some gauge of where our health system is with respect to stress. And it gives a way to communicate that to policymakers as well. Next slide. The ability to load balance is key. I'm going to give an example of the El Paso surge, but we've load balanced across inside the city, outside our region, and have coordinated statewide. So next slide. So El Paso, Texas is on the very furthest west point in Texas. It's probably the hardest place to load balance of any place in the state because of its physical distance away from the other big metropolitan areas. But we load balanced about 180 patients out of El Paso at the peak of the surge. This was done in a cooperative way using the sort of many hands make light work. Many patients transferred to multiple different facilities across the entire state. And it helps load balance and keep hospitals from going into crisis. Next slide. It also, we're able to load balance. This is in the region of load balancing from acute healthcare to long-term healthcare to skilled nursing facilities and rehab facilities. We've load balanced across there, and as Dr. Bulger said, we've the ability to track hotspots as well from skilled nursing facilities. Next slide. Next slide. We've coordinated resources, PPE, testing, staff. We've had differences with respect to PPE, certain hospitals running out of, close to running out of PPE. But when that's shared at a regional level and tracked real time, the ability to load balance PPE, testing, staff, and equipment have worked extremely well. Next slide. We use it as a convening entity to convene expertise in partnering with the public. These are our crisis guidelines that were developed. We have our pandemic medical operations work group that's met at least once a week, oftentimes 3 times a week for the past year, where we basically work to develop a crisis guidelines, which we partnered with the U.S. Office for Civil Rights and disability rights groups in Texas and the United States. And I think it really helps with convening people to do specific tasks, like, for example, these crisis guidelines. Next slide. I know you're all aware Texas came up as the number one concern on the list of concern about Texas. And this is just, you know, a feed from our RMOC, February 17th, 2021. You can see that on the downside of our biggest surge, now we have a weather event that at least it's unprecedented in my 40 years in one location here. So next slide. So we use the RMOC, and this just shows a good example. These are, as Dr. Hunt knows, I'm an amateur photographer. These are pictures actually I took February 16th, 2020, just by chance. I would normally be taking wildflower pictures. That's a bluebonnet and a mountain laurel. And then February 15th, 2021, with this is the same road that it's snowed in and really unprecedented. Next slide. So we've used our RMOC to do these three principles: maintain integrity of our regional healthcare system, coordinate communication, collaborative planning among the different health systems, and collect accurate data. Next slide. So how'd that work in this situation? I will say I got a real-time, this is a screenshot from a Zoom call, but this is February 17th, 2021. This is a water outage map for Bexar County. You can see that the red are places that are completely out of water, which involve multiple hospitals. And every hospital had a water problem because it was tied to problems with the grid and water supply there. You can convene people in a meeting using an RMOC, and you get people crossing disciplines who would not normally be in contact with each other. So I'll give a real world example. The engineers for the water system are trying to decide how to distribute the water. But normally they wouldn't, without an RMOC, they wouldn't have health input. With health input, we can say you must prioritize water to hospitals and dialysis centers. Must do that. And that came across loud and clear, and they were able to flexibly meet that even though they had impaired function at the time. Next slide. So the RMOC function in COVID-19 response in our region has provided great situational awareness. It's integrated those three key systems. I think we've demonstrated the ability to load balance across multiple health systems, even over greater than 600 miles distance. We've managed and coordinated hotspots, coordinated state and regional resources, and been able to convene experts. And the most important thing, I think, is the ability to fluidly adapt to multiple situations at the same time. That's the key advantage of an RMOC. Next slide. You've seen this slide. Those resources are available there. Thank you very much. Next slide, please. Thank you.
Ronnie, great pictures. A couple of things that really hit me from your presentation. And Echo, if you can like prime the pump, don't put up the polling yet, but that'll be next. The extraordinary success with the distribution patients from El Paso. That just like that particular slide was like, that's like a grand slam, just extraordinary. I also think that the story of the flexibility with different disasters coming at you and some at the same time, it's something we've focused on with RAMS. We've done riots in COVID, we've done hurricanes with COVID. We just did on Tuesday, actually, we did the Texas storms in COVID. And the point, that last point that you made, I think is a real take home, that fluid, you know, the ability to respond to multiple and change on a dime is really important. That one question I have for you that I thought about this presentation or today quite a bit, in that, you know, we're talking about the same thing, whether it's the regional coordination center, medical operations coordination center, whatever it is that you call it. And I've got, I mean, effectively, what happened was you and Eileen accepted an invitation to do these rounds, and you are both not just extraordinarily busy, but you effectively are the leaders of the nation's trauma system. And so it's sort of like, well, what's up with Eileen and Ronnie being willing to like make this a really important thing to highlight on these rounds that have just such broad like participation. Basically, we got trauma leaders in the country talking about COVID as it relates to how you actually coordinate a system. Why is that so important to you to be able to like actually show up to do this? Why is this such an important matter for you? And obviously, if both of you are doing it, it's somehow an integral part of the mindset of trauma surgeons in thinking about how we need to move forward as a country.
Well, I'll say for me personally, and I think Dr. Bulger and I feel very similarly, we think that regional coordination of care is really important, which is really at the core of a trauma and EMS system or an emergency healthcare system. Getting the right patient to the right place in the right time, and really cooperation, communication save lives. So to me, having sort of watched this evolution, I've realized that this concept of the RMOC, which is really a health concept tied into a local regional EOC, it really does make a difference in our patients. It really does make a difference in our health systems. The ability to coordinate is vitally important. So that's why it's a big issue for me. I would say also it's a great there's still areas of the country without really a robust trauma and emergency healthcare system. And an RMOC is actually a pretty good starting point for that. You could actually start with an RMOC. And it's also for those healthcare coalitions, for those trauma systems that aren't, responding to other wide scale events, it's a really good way to take a trauma system and make it where it can be a framework for wide scale events. So to me, that's why it's really important.
Yeah, thank you. Eileen, I figure you might want to chime in here, and then I'm going to go to the polls.
Yeah, I mean, I would echo the same thing. I think, this framework gives us the flexibility to respond to day-to-day emergencies, if you want to set it up that way, but also to scale up to any of the various events that challenge the system. And I think that we heard early in the pandemic, in the first spring wave, from trauma centers around the country who were really struggling to keep their doors open for trauma patients because there's such a huge surge in the region, right? And so this affects not only the patients that are sick with COVID, it affects all the patients that have time-sensitive emergencies, the patients that need their stroke taken care of, they need their cath lab, the access to the cath lab for their STEMI. So if we think about this, it's really preserving the capacity of the healthcare system for everybody when something bad happens to them by having some strong stand up quickly, that we have these pre-existing agreements and we can start to move patients around effectively. I mean, sometimes you have to move really long distances, like Dr. Stewart showed from El Paso. We've moved patients from Montana into Seattle all the time, but that's what it takes to keep the system whole and to keep us all out of crisis standards of care. Then that's what we need to do. And but having that sort of available to you gives you a lot of options.
Thanks, Eileen.
Can I make one?
Yeah, please.
We're going to get to polling, but I'm going to just piggyback on that. Also, I think you've worked with the Committee on Trauma for the past 25 years, really, and I think actually everybody on our panelists have worked in one way or another. I think we have kind of a historic view that if you go to about 1960. Like all of the technologic advances, if you think about it, existed. Like as a healthcare entity, we're very technology specific. We're very biologic technology specific. But all of the technology, so the ability to operate, have blood, all those things existed in 1960. But the mortality was still almost the same as what it was in 1913. It was a little bit better, but not much better. Only once we basically formed EMS and new disciplines of emergency medicine, trauma surgery, and started organizing trauma centers, trauma systems, did actually mortality really go down. And so really coordination makes a huge, I'm an evangelist, I'll say, but I think it really does make a big difference. It saves lives.
Yeah, Ronnie, I learned actually the hard way on a specific patient. Sometimes the system can kill a patient, the system, not the doctor, the system can kill a patient, or it can save some lives. And so, yeah, I'm right there with the evangelism. Listen, so time-wise, we have about, for participants, okay, do me a favor, get on, if you can like finish off that email or the phone call and like really focus, come on back in, okay? Really come on back in, and we're gonna do the polling thing. And we've got like 9 or 10, and it usually takes about 50 seconds. So like to get critical mass. So if you could jump on these today, I wanna like get like to at least 50% per question, because this is really gonna inform all of us about where we are with this concept, okay? So, and then after that, I know Eileen's got a job for sure at noontime. So any last word from her? And then Carol, I'm not ignoring you. Dan, I'm not ignoring you. I want to make sure that any comments, questions, it's just that there's a timing thing today. So, all right, let's get some polling up. And so first thing off the top is, and you can read it for yourself, I'm not gonna read it, but this terminology piece, Medical Operations Coordination Center. You know, Ronnie, you had a different term, regional operations coordination, something.
Regional Medical Operations Center.
Yeah,
RMO.
but
It's
one of
same,
the things,
it's the same.
that, so I want to be an evangelist on one of these things. So I don't care. Well, actually, I care a little bit about the name, but if we can get to a generic name that everybody's operating from, that actually will help. And I go back to what trauma surgeons taught me a long time ago about like the common language that ATLS provided us with. So if we can get some commonality around that, that would ultimately be great. And I, like I said, I don't have a dog in the fight, except I was thinking about using the regional terminology for these. And then I went, well, wait a minute, let's use the mock thing. So it's the similar concept that I'm asking you to respond to in these polling questions. All right, let's stop there. 52% voted. Let's see, take a look at the results. There's a lot of opportunity there with 22% that said it didn't exist. A lot of opportunity there.
It's not too hard either, Rick. I know.
Yeah.
I know people think that it's like you know, you can scale it. You can start small, and I think if you start small, you'll get bigger. But it's just the concept once you do it, and it's actually a lot of fun. This is a lot of fun to do this. You develop friendships and partnerships. You know, it's very doable.
I think also to follow up
Next.
with your
Go
comments.
ahead and put the next one up, and then Eileen, keep talking. Yeah, go for it.
Comments earlier about how do you get the CEOs and when it's not a crisis? I think first of all, they see the advantage of this when there is a crisis. And what we've said is always said all along the lines, if they have the capacity to level load within their healthcare system, they can do that. But when they're in trouble, we have their back, right? So we're not forcing them to, but I think that relationship has worked really well, and we have sort of a standard agreement that they've all signed, and they know it's not going to be scaled up unless there's a big event, but
Right. All right, just about 5 more seconds on this one. We got 48% have voted, 50% voted. Let's stop there. That's interesting. I had no idea how that was going to play.
It's interesting.
But 19%, 24/7, 365. I'm actually, I mean, that's to me encouraging. I think there's certainly, I mean, Ronnie, you and I were talking about, put the next slide, polling question up. We'll just talk through these. Great, this one's gonna take I got a lot of options here, so you're gonna have to read that. The conversation we kind of started around like the scalability piece. I mean, this is a personal observation. When there's something warm on, and I actually can remember a couple of night shifts when like the emergency department had 0 patients for like 10 minutes. having like something there, like turned on, the lights were turned on, the staff was there and ready to go. It's so, to me, trying to like restart is hard. I mean, that's my own personal bias about it. I think you're right. You can probably do it from de novo when you need to and just kind of like walk in, turn the lights on. But that's a personal bias of mine.
I think it works well scalable. That's what we use our MedCom. It's just a normal, it's a normal, deals with many little disasters all the time and does a bunch of coordination of transfers. And so therefore they know everyone in the region. And those same communicators form the core of the RMOC. Once it happens, it just scales up to be something different. But that approach does work well.
And also it costs money to keep the lights on too, for sure.
It does, but there are also advantages. I mean, I think if you're an emergency physician who works in a more rural area and you have to make 25 phone calls to find a home for a patient with a complex problem, you know that there's a benefit if there's a centralized structure where you make one phone call and they find
Available. Darn right. Wow. All right, stop there. We only had 40% voted, but at least we got some input here. Identifying available beds looks like the number most frequent response, then addressing PPE shortages. Fascinated that the load balancing isn't higher. There's, believe me, Eileen and Ronnie, there's no science behind these polling results. It's just like, it's not like double randomized control trials. So anyway, next. Okay, this is who is actually leading your mock or whatever it is that it's named. I see the comment about I didn't have a I don't know option, and yeah, this is like this polling thing. It's not like you had the Gallup poll people pull these together. I'm just saying this is winging it, trying to get best possible information as fast as we can here. Another 5 seconds on this one. I'd like to get a few more responses out of this for this one. Yeah, there's a lot of I put is led by, there's a lot there. I get that. All right, let's stop there. I took a little bit longer for this one. I think like something like 39 or 40% voted. Interesting to see healthcare coalitions like top the list.
I think that's good. I think that means we have a framework to build on, right? I mean,
and also your story too about you had the healthcare, then your story that in particular is really important. That then you were able to finally get the MOUs. Yeah.
Right. I think we leveraged the relationships that were built through the Healthcare Coalition, all the planning work that's gone into regional disaster planning.
Yep.
To move to this next phase. And I think, this is a great foundation that we have in the country. So if we can leverage our healthcare coalitions to start to think about this structure, then that's a good starting point.
Yeah. Thank you. All right, next. Yeah, go ahead, Ronnie.
I was just saying the STRAC is a not-for-profit 501c3 that is in essence our healthcare coalition and is tasked to do a whole bunch of different tasks. But I think it is great that those lead, that's the most common response. But I think also a MOCC could basically be a way to get a healthcare coalition going as well. It's possible to do it in
wow. I had not thought about that that flip there, Ronnie, but yeah, I get it. Yeah, it causes people to come together for a common purpose, and from that you can build on it. Yeah, and it goes back to what I mean. The theme, we talked about throughout this whole thing is the building the capacity and to collaborate in a way that can get to a common purpose. I mean, that's the whole thing. So another 5 seconds on this one. All right, let's stop there. We had 37% voted. Interesting to see most responded it was in an EOC led by emergency management. There's a lot of other too. You can put in the chat where where that is. I put virtual. What the heck? I mean, all right, next. Our region's mock or similar has representation from, and it's a select all that apply one. In particular, I mean, I think there's some core ones that are pretty obvious, but click quickly. Eileen, I know you got to go in a minute, so.
I do think, I see the Hospital Association here though, and I would say that's another great group, right? Existing relationships between the hospitals, particularly at the administrative level. That's another great group to leverage if you're trying to put this together.
Yeah, and actually for everyone's awareness, for the first time in ASPR healthcare preparedness program, we actually have some cooperative agreements with hospital associations, which is, yeah, finally.
I think this is great. These responses show all these, to me. And I think, the general principle is to be maximally inclusive in the area, to involve every stakeholder who's involved. That's a key principle.
Yeah, Ronnie, I'm actually really surprised. I mean, you and I are seeing these real time, but the participants haven't seen them yet. I'll give you like 5 more seconds for them to.
Oh, sorry.
No, it's no. They don't. Yeah, it's like it's a secret. The big reveal. Go ahead and do the reveal thing, Echo. Echo, thanks for doing so well with the polling. I appreciate it. Yeah, there's a lot going on during rounds. That just is. Look at that though. Lots of, I mean, wow, that is extraordinary. That really is, especially, I would have hoped for it, but the long-term care facilities for sure. Let's do the next poll. And as we do the next question, because there's I think 2 or 3 more. As we do those, I know Eileen's got to go. So Eileen, any last word from you, and then Ronnie, you as well, while people are doing the polling, and I'll send you the poll results. Okay, so
yeah. No, just to thank you for the opportunity. You can see, I think that we're fairly passionate about this and really willing to help any state region in working on this. So feel free to reach out to me or to Dr. Stewart, or to the ACS, and we're happy to share all the resources that we have. Microsoft has offered to share this data platform for free. We can put you in touch with them. So don't hesitate to reach out if you want to help work on this. And I'm going to run, but I apologize.
Eileen, thanks so much. That the Microsoft, that one, that's pretty cool. Really appreciate your time. And I think there's a lot of interest, energy that you've generated on these rounds that we'll try to continue to move forward with. So Eileen, thanks very much for your time. I'll send you the polling results.
That'd be great. Thanks very much.
All right, Ronnie, if you can hang on for a second, or you got to go.
I'll hang on.
Great. Because I want to make sure, I mean, seriously, Carolyn, poor Dan over there, I've shut him up the whole time, and not purposely, but I got to keep the thing going, All right, so and Amy and Amanda, thank you. I think there's only 2 more left. The number of FTEs needed to support, and this has to do, the reason I threw this in here, Ronnie, specifically was Matt Watson, who's working with our program, said, there's this whole finance piece around this. So how much is it going to cost? The FTE thing obviously comes into this. So, gosh, 5 to 10 days, couple 5 to 10 days. Wow. All right, let's stop there. And you'll see 1, 2, and then 5 to 10. 5 to 10, wow. Okay. make sure everybody gets a chance to see it for like 2 more seconds, and then let's do, I think it might be the last one. All right, next. Ah, yes, this is the last one. Last but not least. And really, if you can stay on long enough to like respond to that, that would be great. Hey, Carol, after this polling is done, I'll go to you first for any questions, comments, then to Dan, and then to Ronnie for any last comments before we close out. And hey, participants, thanks for jumping on these. We've touched on these coordination centers before, but the information in the polling, getting a snapshots, pretty fascinating to see where we are today. All right, let's stop there. 65% who are still on voted. Pretty not surprising about the key partners unwilling to collaborate. Also, thanks for the other reasons put in the chat there. Appreciate that. All right, so Carol. Oh, wait a second. I don't think we showed the polls. Did we? Did we show the polling results? There we go. Okay. It got a little ahead of myself. Sorry. See that 14% there, the partners unwilling to collaborate. Surprise, surprise, huh? All right. Let's stop there with the polling. Echo, thanks for the polling. Appreciate you popping them up there really quickly. Carol?
First of all, I'm very impressed by this. I served on the Institute of Medicine's committee writing the Crisis Standards of Care Toolkit, and I love the fact that you actually list some of the triggers that indicate that you might be in trouble. I think one of the biggest downfalls that we as an entire healthcare system have, whether it's a big system or a rural system, is realizing that trouble is coming. You're too busy managing the shoveling the snow pile before you realize the avalanche is coming. So I love this. I hope that we put it on your list, Rick, for national support of something like this. I think it's great.
They're in that national support. I mean, the healthcare resilience work group that was led by FEMA that I was on, we really pushed hard on the mock thing. And it's not clear to me that, it's like in the forest with a tree falling. Was anybody listening out there? And yet you see, big places. These are not like, small islands. Texas,
Yeah.
Washington doing this. And yet I don't know. But without it, it's clear to me, people probably have died. I don't.
Oh, they have. There's no doubt they have.
At all. And so, what the heck? Plow through the barriers. Okay, thanks, Carol.
And no state boundaries.
And no state boundaries.
Yeah.
No state boundaries. But that's a key. No, because Ronnie, it's interesting. Both yours are Texas and the state of Washington, and country Texas, country of Washington, whatever. But they're big, yet you already got to the cross in the state boundary. That's kind of a non-thing, really. You crossed it, but I think people get so much ingrained in this sort of like the state and the governmental entity thing. And gosh, if ever there was a disaster in a century to plow that one down, I think it's this.
It'll be one neighborhood.
One neighborhood.
Everybody's in the neighborhood.
Dan, you get your shot here.
Yeah, thank you.
Dr. Stewart, thank you. Outstanding job. I mean, since R.A. Cowley, talking about systems, Ken Maddox, first, talked about trauma systems in his book Trauma, which I know you were a contributor to. Emergency Medical Systems Development Lessons Learned from the United States of America. That's a book that was written by PAHO. They talked about the emergency health system, right? So how EMS fits into EHS and how EHS plugs into the public health service. 0 preventable deaths, right, by the National Academy of Sciences. We've been talking about this forever. It took a pandemic to show how well that it worked. How do we continue? So my question is, how do we continue to capitalize on this? I mean, everybody's written about it. We proved that it works. How do we make this become the standard across the United States? How do we capitalize on this energy? And again, Doctor, thank you again. What a great job you did. Really, it's an honor to be here with you today.
Well, really, it's not me. It's obviously a whole team of people, and I think the places that have they have sort of like a baseline of regional care, and a lot of the places I think are I mean, it's I don't want to extrapolate too much, but in both Washington State and Texas, we're used to transporting patients for doing interhospital transfers and transfers of patients long distances across state lines. It's really spread out. So maybe that helps. But I think the key is we need to, as the emergency healthcare community of all our organizations working with HHS and ASPR, we need to basically work to fill in that patchwork quilt that's missing, where there's missing along emergency healthcare systems. And I think the RMOC is it's a great starting point for those who don't really have a regional system. Because the principles of the RMOC are the same as the principles of an emergency healthcare system. And I think if we come together and advocate for it, I think it'll happen. I know we can do it. But I think it takes, across the disciplines from public safety, first responders, EMS, emergency physicians, trauma surgeons, trauma centers, public health. I do think we'll get more data that shows that it does work. It makes sense that it would work. It lines up perfectly with the past 30 years of research that shows that it works in individual conditions. That's what I think.
Thank you.
Thanks, Ronnie. Dan, thanks for the question. And to our as we close out, to our participants, thanks for jumping on the polls as quickly as you did. It really helps us all get at least a snapshot. Some of the results were actually really gratifying to see some of the progress made. Then the other piece on participants, in response to the crowdsourcing question, I saw a number of responses about the variants being on people's minds and vaccine reluctance. And I want to point out 2 resources for those of you who did have that comment, and others as well. We did a rounds on Monday, yeah. Echo, correct me if I'm wrong, on vaccine reluctance in EMS clinicians. While it was specific to EMS clinicians, I would say there's a lot of generalizability in those rounds. And I would refer you to those rounds for sure. It's a really great dialogue about vaccine reluctance in healthcare providers, in clinicians. And then on the variants, I would very much recommend to you the NETEC webinar on variants that gets you a great baseline of information far beyond what you see on nightly news or whatever media you're watching right now, because the papers aren't out yet. So with that, thanks participants. Echo, always most grateful. Dan and Carol, thanks for being patient with me today. I was trying to get a lot done and make sure that we got some stuff highlighted, and appreciate that. And while Eileen had to leave, most grateful, and Ronnie, most grateful to your time. And personally, it's great to see some colleagues and friends on the rounds. And I meant it when I said, yeah, the trauma surgeons have really stepped up in this particular disaster. And I'm just hopeful that all the clinicians who aren't trauma surgeons, when those big ones come in trauma, they can help you as much as you've helped those on the other side. So with that, Thanks very much all, and we will see you on the next one. Bye.
Thank you. Bye-bye.